Yes. All right, so I think we're going to get started. So I'm Clare Liddy, and so I'm family doctor for those of you who didn't know that. Work clinically over at the Ottawa Hospital Family Health Team, Riverside site, and then health services researcher. So you heard the great presentations by Chris and Tala in terms of the medical education piece on eConsult, and we're going to shift gears a little bit, and I'm going to basically take the opportunity to give you some updates and highlights, exciting news, well, you've probably all heard it, but about kind of where we have gotten to now, essentially from eConsult, which literally started with a conversation that my co-creator and colleague Erin Keeley and I had over a cup of coffee 8 years ago now, because I had referred a patient for a visit at endocrinology, complex patient with diabetes, and I had, I'm a good doctor, I tried to do as much as I could with that patient, but basically that patient did need that. They needed the visit and I needed the advice, and it got triaged to a 9-month wait list. So imagine me then telling my patient, okay, well, you're in the clinic and it has been looked at, triage, so you're not urgent, right, and they're going to see you in about 9 months. So it just did not sit right, and it didn't sit right with Erin either, who at the time was the chief. So we've taken it from that conversation that we had, just really all about the problem, and then developed the eConsult service with a whole bunch of now partners, research funding, and now program level funding in Ontario from the Ministry of Health. They've been partnered with us for a few years, but this one is now a substantial amount more. And many people in the room here, so Justin, Isabella, who else is here? Barb, she's done some stuff with me too. Anyways, and then obviously Chris and Tala, Sheena, Doug, so and Gwen, who you'll hear from later, Janessa in the back, have all touched and are working on eConsult. So I think I spoke to this, but I always, on every talk I do, bring it back to that, because I think that this is, when we then talk about evaluation research, what are the research questions and all of that, the fundamental reason and the fundamental question that we wanted to answer and try to, or problem we were trying to solve, as I said, was that access problem. So instead of 9 months of wait for endocrinology, 2 years for pediatric ophthalmology, et cetera, could an eConsult basically improve that access? And then what would the other impacts be? So you've heard about this. So again, in the end, it may not result, so the patient may not need to have that face-to-face visit, but that was not the intention of creating it. The intention was to get the advice. Whether you need the face-to-face visit or not, you will get it if it's appropriate or if you request it. So I'd like to emphasize that. So how does it work? I will actually just talk a little bit more detail through this, just to make sure everybody's on the same page. It is a one form that you go on to, a web portal. So one form meaning the primary care provider completes the same form for the 109 different specialty services now that you have access to. So a really different flavor than what's been happening with e-referral, where there's a lot of mandatory fields. And we've kept it very much and really hang on to that primary care perspective. You send off your question, attach anything. So you can even attach a video, which we do have, attach images, attach a usual referral letter, labs, anything that you think is relevant. And as Chris and Tala had indicated, this is a conversation. So the interesting, Chris said, people didn't really care about the grammar, because the whole point is that I just want to type off and I'm sending a question directly to the specialist or specialty group, and then they're going to answer me back. And I'm not too worried about whether there's a small typo or, did I capitalize everything, because it's actually, and what you're going to see, and I need students who are interested in language and conversation and that piece of it, the relationship piece, to start taking a look at that, because it's very different than a formal referral letter. At the end, the primary care provider completes a survey, and so I'm the one who's really in control of it, and I answer the questions plus the free text. So from the one patient who was going to wait 9 months, we now are, and I think actually we're over 35,000, so cases completed. Those are people in Ontario and primarily still in the Champlain region have had an eConsult over the last few years, and we've we started only with, okay, what if I, as a family doctor, could send an eConsult to endocrinology, so one specialty service, and obviously that was Aaron. If I could do that, it immediately actually went to, when we started to do our research project, to 5 specialty services, because the group of family doctors who we initially engaged said, okay, we don't really have an access problem with endocrinology, but boy, I could use derm, cardiology, neurology, and so on and so forth, and that's how we built that. I think because of our responsiveness and kind of building up, we've had tremendous growth, and this has been very organic, meaning I don't have a big team. I'm primary care engagement. And so, as Chris had said, we have 80% of all primary care providers in our health region. So that's over, with nurse practitioners, we're way over 1,000 basically have joined the service. Not all are always active users, which is something that we're now going to tackle, but they were interested enough. They also had an access problem and thought, hey, eConsult maybe could help. What do patients think about eConsult? And what I'm going to show you is our snapshot. We've done a lot of evaluation across 4 basically aims. So the quadruple aim, which is looking at that if you implement a health service improvement, it should improve the patient experience. It should improve population health. It must be done in a cost-effective manner, because otherwise we won't be able to afford it long term. And then the 4th, or quadruple aim, is it should improve the provider experience of care. And I think you've heard already through Chris and Tala a lot of evidence on that. But patients must be in the loop. This is about them. And we did do quite a bit of work, especially early on, to see what people thought. So we did surveys, and Justin actually had done the patient experience survey. We asked people after they'd had an eConsult a whole series of questions about it. So she took photos of both my hands, sent them through eConsult, and within 24 hours was back in the office with a prescription. So how amazing is that? People are really happy, very helpful, happy it was available. And this came up as a big theme. It kind of gives me peace of mind. And I know when I initiate a referral for any of my patients, even though I can tell them, this is not urgent, don't worry, we just need to get the advice. I know that people go home and they, tell their family members, my family doctor just referred me to cardiology, must be a big problem, right? And then they wait. So again, the eConsult service from the patient's mouths is like, okay, this was amazing. Within 1 week of when a problem was raised and the family doctor or nurse practitioner thought I needed advice and needed some additional help, maybe I need more, that I'm actually having some kind of response, a plan. So the plan could be, yes, I need that face-to-face referral, but actually they're going to set these 2 things up before, and then we'll see, right? Or yes, you still need the face-to-face referral, but we're going to try this treatment. So that's the type of thing, and our patients who get to have an eConsult are hugely appreciative of that. And in addition, they really feel that they love actually the fact that it's their primary care provider who's continuing to manage their care. So there definitely is fragmentation, poor care coordination as soon as you go out of your medical home, and being able to keep it in and really have a communication platform that enhances that and enables the primary care provider to have the backup basically is really good, and patients have been very positive about that. So what they didn't find an issue with, because we specifically asked about that, they had no concerns about the circle of care. They didn't have concerns about having to do a very big informed consent. It's implied consent. So they trust their family doctor. They had no concerns about privacy, no concerns about the transmission of whatever the family doctor thought they should send off to the specialist out in this virtual eConsult. So those were all basically no concerns raised in our patient interviews. In previous studies, they have brought up that, well, hey, this is great, but in this particular case, maybe I would have liked to have seen the specialist, or I would like to, in which case, that's fine, you see your specialist. And the other piece that was brought up is that we did surveys in waiting rooms. Actually, my family doctor was not the one who referred me here. So how would that work, right? And so that's where in early studies it was revealed that across clinics, 30% of all specialty visits are not initiated by the family doctor. So as a family doctor, I was quite surprised at that number. I find it quite high. And then the other piece is that we'll talk to patients who are in specialty services, and they'll tell you, well, I don't have a family doctor. So how would, if I don't have a family doctor, how can I access eConsult? So there still are people out there who don't have that relationship and don't have a family doctor, and it's something that we're very aware of. But all in all, it's very well received by patients, and they can refuse. They can say, no, I prefer you don't do that, just do the visit, book a face-to-face, that's fine. So how did it impact access? And these numbers are staying very stable, so statisticians in here will understand why that is as we increase our sample size. But man, it's amazing, and as we go out into new regions, as soon as we hit 100 eConsults, we're getting like a pie chart that looks identical. So when you do an eConsult, you get asked at the end of it as the family doctor and nurse practitioner, was referral originally contemplated but is now avoided? So we're seeing that basically 39% of the time, so out of all of those patients, I was going to refer you for face-to-face, I had access to eConsult, I did an eConsult, I no longer am initiating that. You get asked, was referral originally contemplated and is still needed? And we want that. We don't want to, we're just improving access to advice, not eliminating face-to-face. So 25% of the time that happens. Was referral not originally contemplated? This is the green. I wasn't going to refer, and it's still not needed. Okay, so then people are thinking, and specialists might say, well, I don't want the family doctor to just send off any question that they could have looked up, right? How come they didn't look it up on UpToDate or whatever? But actually, what we see is that these are very patient-specific, and we want people to do this. Why? Because the next piece of the chart question is referral was not originally contemplated, but the eConsult resulted in me initiating one. So we're seeing that in 4% of the time across all cases, and we're starting to now look at the different specialty groups and identifying actually where there are some higher numbers. So urology is one of them, really interesting, and basically 8% of urology eConsults are resulting in a face-to-face being initiated, where the family doctor at the time wasn't thinking that the patient needed it. So that's a really good pickup. It gets people into care for what are potentially, and the urology ones are looking like it's basically earlier cancer detection as a result, again, of the access to eConsult. Eventually, the patient probably would have had a progression of symptoms and you would have done it. But we want this number to stay, basically, because we don't want you to filter out. We want you to ask what you think that you need to ask. And we know across all of them, 4% of the time, you're actually going to be told, okay, I should initiate a referral. And very few, there was no benefit or something other. And those numbers, as I said, as we spread and scale, are remaining constant. And what I've been trying to do as we spread and scale is have the eConsult systems built with those questions built right into it in the same way we did. I think we know about the educational value, excellent educational opportunity. I didn't need to worry. I got extra education. I've shared this learning opportunity with my residents as well. So a lot of basically capacity building. Clearly I'm biased about eConsult, and I'm very positive stuff, but what's the impact on a population health level? We're trying to get at that. We always get asked about, okay, well that's great that the patient gets more rapid access. But I'm a specialist, I have a 2-year waiting list. Tell me about what's the impact on the face-to-face referral? That's a hard number and a hard thing to actually capture because the data is still, like in the hospital, is very, very poor. Nobody can give me from the Ottawa Hospital what is the true waiting time from any of the clinics. So once Epic comes in, that's what I'm being told, they'll be able to do that. But anyway, so we looked at it and did just a cross-sectional study. So we had a control group and looked at the folks, people who are using eConsult, who have enough use of eConsult. And if you're a primary care provider and then you're telling me that 40% of the eConsults you put in are no longer generating a face-to-face referral request, then it should, the hypothesis would it'll decrease your overall referral rate. And we're also, as we said, we know there's capacity building and learning. What does that do on your individual referral rate? And lo and behold, this is through an ISIS so health admin data. Isabella worked a lot on that one. And we did find an 8% decrease on the referral rate. So one group of providers who use eConsult compared to a matched control group in Ontario who don't have and are not using eConsult, and the group who use it have an 8% decrease. So it's a trend. It's not a massive control, like randomized controlled trial. There could be lots of other reasons, but definitely it's significant in the sense of a clinical significance. So if you then equate it to the number of referrals, and then I'm all about trying to get spread and scale. So I have, I do make provocative or whatever, bold comments like this too, because I talked to the government and I wanted them to adopt this. So that would save $4 million over a year, just in that small group. So overall, this is what I've been busy doing. We've created an evidence base for eConsult. We knew early on this looks like this is going to be really effective. It's transformative potentially to the health system, and we really wanted to drive the message home. So these are the quadruple aim, and we have 42 publications now in basically all of these quadrants. And the interesting thing, and I'll get into this at the end, is that basically you'll see policy implementation articles here, because what became obvious is that we weren't going to be able to spread and scale eConsult across Ontario or anywhere else unless we as a team started to look at what the policy issues were. So that's a very different realm for a researcher to sort of step into, but absolutely we did. And so now we have publications. So I did the research thing and I decided, well, we'll research policy to the best of our ability. So winging it a bit at the beginning, but actually now, in fact, making quite an impact. So somehow we're going to call, this is our 5th aim, basically. And you can look on our website and there's lots of, I said the articles are all there, but I gave you sort of a snapshot across. Does it improve the patient experience? Yes. Does it improve population health? Overall, we think so, the 8% decrease. Does it improve the provider experience of care? Absolutely yes. And is it cost effective? Yes. So now what we've been doing, and through research grants, I got a Knowledge to Action grant, Partnerships for Health System Improvement grant, and this was building on the Advancing Primary Health Care for People Living with HIV grant, where we already had partnerships with Manitoba and Newfoundland. So over the last 5 years, essentially have done a lot of work trying to spread and scale this across Canada. And I'm really proud to sort of let you know that essentially today, as of today, we have live eConsult systems, full replication in Newfoundland. So more than 1,200 patients now in Newfoundland have had eConsult, and they are in discussions, and they're going to get basically program level funding from their Ministry of Health in Newfoundland to support a further rollout. We're already providing access in Nunavut, and that's having a huge impact. That has over $1,000 per case cost savings right away on safe travel. Quebec went live last July in Outaouais, so I went naturally to the region that I knew that they had an poor access problem. It's subsequently spread, and we have Abitibi and Trois-Rivières who are involved, and the Quebec government is also going to now give program level funding to incorporate it fully into their system. And Manitoba is also live. They're fairly new, but basically have done also a direct replication of our platform. And then, last but not least, after a lot of work within Ontario, it's sometimes hardest to actually get traction in your own region, but we've done it, is we actually ended up replicating our system on the Ontario Telemedicine Network, and then basically got funding in 2017 in the Ontario budget, which was amazing. This was actually in the budget document, and I didn't know until I saw the budget document that finally something was going to happen. But building on the successful Champlain-Lynn-based eConsult service, the ministry plans to expand the service province-wide in 2017-18. And so that meant there was money allocated. We had no idea how that was what was gonna then happen and what our role would be. And again, it's not a very common role for a researcher, but that's why I got into policy research, because it kind of let me straddle the divide. And then what happened is all of a sudden, just before Christmas, which meant that I did a whole bunch of work over Christmas, they created this program. BASE will be the reference model for regionally focused managed services as they become ready. And then at that point, we started discussions about, would you like to have and set up the Ontario eConsult Centre for Excellence, housed at the Ottawa Hospital and BRI. And so the answer on that one was yes. And it finally got signed off, and we got the minister's letter, I think, on March 30th. And so we have just basically literally launched it. And I am the co-executive director with Dr. Keeley, who's my other co-executive director. So what that means is that we have been given basically a good budget, and more importantly, it's about having the authority to implement and roll out the Ontario eConsult program. These are some of the things that we're going to be doing. So it's a big job. That's why I'm now on sabbatical. So my sabbatical is here. Lots of Toronto trips. Basically, this is what we're responsible for. So it is a very big accountability and deliverable package. I think what's really neat from a research side, though, is that I was able to, in our key deliverables, actually implement, some research language, and I will be doing so. The research language here: collect, interpret, disseminate, discuss key quality utilization metrics. So the language of the ministry right now is that's the benefits evaluation. Okay, and we'll be doing that. And from that, we're going to have research publications. Now, it's obviously not a randomized controlled trial, but I don't care about that because actually I don't feel like we need to do it anymore because we have spread and scale in that sense. And then conduct policy research. So that's actually, these are, in addition to the other ones, those are, things that I'm going to be leading, which allows me again to straddle that research and implementation or program sort of divide. So out of that, then with Justin's great support, I got asked to write like an opinion editorial. Hey, what's that? I had no idea. CIHR said, we just want to help you spread the word, and basically wrote, and it was about what are your lessons? How do you move innovation into practice? Which clearly we've done. Gone from pilot to program to full spread scale across Canada. So these are my 4 tips. Straddle the divide between research and practice. So I absolutely leveraged research funds to then do some program implementation stuff, to then try to get, 10,000 here to do a specialist survey that's then a research paper, but that informs, right? So very much jumped back and forth, and it gave us a lot of flexibility. This was a technology project, as you can see, eConsult, but it actually wasn't a technology project, and it still isn't. So it is the vehicle. It is the tool that we happen to land upon as a solution to the access problem. And I have always maintained that. We've kept a very, very firm line in terms of any vendor relationship and made it agnostic, so it's not based, it was an off-the-shelf system. You could go buy it, off Amazon type of thing, and then do the development. There was a little bit more than that, but that's the essence of it. And then when we've done spread and scale, we made a very deliberate decision not to commercialize any component of it. We could have set it up in a not-for-profit, blah, 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 and sort of patented it. And we actually, Erin and I made a decision in Amir about 5 years ago that we would not do that. Why? Because I just wanted to spread and scale, make it easy, and we decided we want to give all the knowledge that we can a way to essentially drive improved patient access. Stay flexible, but stay focused. So a lot of people, as soon as they hear about this, hey, interprofessional communication platform, that's great. I have this other problem. Could I use the platform to do that? Could we just tweak it and modify it? Could we let this person have access, right? Because I think that the tool needs to be used in that way, right? We can use this in memory clinic. We can create like a, we need more than 3 delegates to have access, etc. So tons and tons of requests like that. They're fascinating, they're interesting. I'm very interested in supporting all of those ideas. But the core piece that I want to get established first is primary care provider communicating to the specialist. One form, simple, eConsult. So let's get eConsult going. We'll parking lot that. I'll be part of your project, but we never adapted the platform in any way once we saw this works. And that's how we have maintained it. So we kept in scope, and that allowed, this has been a lot of work, and it really, you can't do everything, right? So always try to keep in scope, and the scope too is what you want to use eConsult for, actually addressing an access issue. Is it because you have a wait time issue? And if the answer was no, then we would not basically go into that area. And then I think the biggest thing is take risks. So in the article we wrote about how as a researcher, you know that you do so much and you get rejected and you fail, if you want to call it that, and then you learn from it. We did a technology project once where nobody adopted, nobody used the tool. So you work on it for 2 years, it was a registry thing, it looked great, we had engagement, right? And then in the end, nobody used it. Why not, right? So is that a failure? Is that project didn't go anywhere, but did it not? Did it actually inform then how we approach things with this? And absolutely it did. So my big message is expect failure, you learn from it, you're used to it, go for it, take the big risk, dream big, You know, and I think as researchers we do that. When you deal with bureaucracy and government, they don't do that at all. And it really makes people afraid, and they go into their cocoon. I have to say, it's very, so you have to just keep pushing ahead. And having research dollars to, I think, support some of your ideas and let you play in the sandbox is a really effective way. You cannot expect the Ministry of Health to give you program level funding to test something new when you can't tell them, you know, how is it actually going to work and how much is it going to cost and so on and so forth. So our biggest risk, I would say, throughout this would have been the whole issue of how do we pay the specialists. So we paid the specialist out of initially a research grant, $100,000, and a bunch of it was earmarked to pay the specialist on eConsult. And if I had done a very traditional research sort of approach, okay, we're doing a pilot, this is great, we have 100,000, it's 18 months, and at the end of 18 months, yeah, we're out of money. We're now going to do our evaluation, right? And I'm going to write the report and make it look good. Not make it look good, but sort of, you know, complete the work. We had no, we knew we were going to run out of money for the specialists, but we also knew that, hey, that we've landed upon something that has a lot of potential. So we need to keep it going. So we decided, okay, well, we're going to keep it going. And then again, got very creative about, okay, well, where else might we get a small amount of, you know, money to support the specialists? And basically, we did run the project, and with the specialists, maybe do some of it for 3 months without being paid, right? Okay, and they did, you know, actually, I think in the end, nobody didn't get paid for it. We managed to sort of string it along. And then for those of you who know the Ontario context, well, there's no fee schedule government agreement between the doctors and the Ministry of Health for 4 years now. There has not been anything. So again, if we had relied upon the fact that, well, we'll just get it running and the fee code will get sorted because they're in negotiations, this whole thing would have basically fallen flat. So again, take the risk. We never felt like we needed to shut it down because we didn't have it figured out what was going to happen in 4 months. We just basically took the risk that let's keep going, let's keep working on it, let's see how we can basically manage that aspect. And so 8 years later, that's what we did. So I would encourage you to take risks. You are going to fail. You should fail on stuff that you're doing. You're going to learn from it. You need to throw your hat in the ring. You've got to submit papers, submit grants, and you know, some of them will end up coming back and actually having a huge impact. And this one was my little project that was on the side of the other major research program that I had until basically a few years ago. So again, a small idea that then has had a lot of impact. So I think I'll stop there. So that's my story. Time for questions? Yeah. Yeah, Debbie? Yeah.
So when you're expanding, I'm presuming none of the specialists are actually here.
That's right, yeah.
Are you getting specialists in other parts of the country?
Yeah, yeah. Yeah, so what we've done is it's basically a regional or creating a local community of practice. So when we went into Newfoundland and they started in St. John's, they engaged the specialist community in St. John's, but as they've gone up into, there's 4 health regions in Newfoundland, so they've been engaging the local community. Manitoba, it's the same thing. We're down in the south right now, but then we're going to go north of 50, so that's quite far north. And then same thing, look around and engage sort of who are the local specialists. So in the north, the interesting thing is that probably a lot more may be answered by internal medicine specialists because they don't have the sort of subspecialist type of availability in the local community. But what we're going to do and what we're doing now actively in Ontario is, I'm calling it, we create a provincial umbrella service. So the provincial umbrella is, and right now I think we'll have 50 specialty services that will be available, and they will be basically offered by the specialists who we're already working with, but it could be for any patient across Ontario. And then we have the same principle in Newfoundland and the same principle in Manitoba and other provinces.
So you're having to run separate incidents of the software so that you make sure that the Ontario person is answered by an Ontario doctor?
That's right, yeah, it is, yeah. Right now it's still provincial, but one of the policy pieces that we've been looking at is interprovincial and interjurisdictional rules around providing eConsult. Because really what I'd love to do, so now the next big vision, you know, if I'm going to come back here in 2 years, it will be that I'm telling you we have a national level eConsult, like national umbrella eConsult service, which then is available for all of the gaps, in particular for the north. So, but that does require again, it's all policy motivated, sort of there's policy rules in place that are barriers that have to be blown out of the water. Essentially, got to get people to think differently, and then make the rules in a way that would then allow that. And then on a national level, one of my grants was about putting together sort of a national policy group, and so we thought, well, who do we need? So we have the colleges. So we got the College of Physicians and Surgeons of Ontario plus other colleges, the Quebec one, for example. We have the College of Family Physicians of Canada. You met Tanley Horsley at the last one, so she's our Royal College rep. And then we have Canada Health Infoway and the Canadian Medical Protection Association and the Canadian Patient Safety Institute. And we've had discussions also with Accreditation Canada. But we have 6 national partners. Did I miss anybody? Isabella is the one who...
Canadian Nurse.
Oh, Canadian Nurses Association, that's right, yeah. So they are basically we have a policy working group, and they really are the ones who are sort of having a lot of the conversations in terms of first identifying what the current policies are that might need to shift, and then helping navigate some of the conversations to get a change. So one of the really great ones that happened in Ontario was the whole issue of the nurse practitioners and the referral process. So when we first started, eConsult, a nurse practitioner, really had limited access to do a referral to a specialist directly, and the way that they controlled that was because of the billing code. So a specialist couldn't bill a consultancy fee if a nurse, actually I don't even think a nurse practitioner could, I'm looking at Rachel because I don't think a nurse practitioner could even initiate a referral request. And yet, in Ontario, they had already established nurse practitioner-led clinics. So how does that work? So that means if you're a patient in an NP-led clinic and your primary care provider can't do a referral, that doesn't make sense. So we actually offered, so that was the firm but flexible. So we, as part of our work, they asked nurse practitioners, it was Smith Falls, they had no family doctor at that time, now they have lots, but said, could we join this? And so we took it to our steering committee, and the answer was yes. They have an access problem, they're a primary care provider. The policy barrier was the payment thing, that didn't matter, it was a research study, and we were paying. We were basically making the payment rules. So we did it, and then what's neat is I think 2014, and there was a policy shift in Ontario, which changed the rules around referral. And it definitely was we definitely influenced it. We weren't the ones who, maybe put the agenda on the table, but we definitely influenced it. And we published a paper showing that here's how nurse practitioners use eConsult compared to primary care providers, raise these types of things as a policy issue. But and that still exists in some other provinces. Rachel, that's another project you can do, policy scan on that. But some of the other provinces still have a lot of constraints on a nurse practitioner, and really, if the nurse practitioner is looking after people as a primary care provider, they should have access. It's not equitable if they don't have access to the same sort of suite of services. Long answer. Sorry. Other questions, Michael?
I'm just wondering, are there other regulatory impacts? That's a regulatory impact.
That's right, yeah.
Are there others?
Well, the other regulatory aspects that we looked at, one of them, I think Chris has touched on it, so it's the quality assurance piece of it. So we get asked that question a lot, and we're trying to tackle that. And my answer is always, well, could you show me how you monitor the quality of a usual referral? How do you do that? We'll replicate your process. There's no process. So there's that aspect of it. The payment aspect, obviously, remuneration is something that is a very hot topic. We've done a policy scan across Canada looking at the different models. There's trying to apply maybe what some existing telemedicine policies are to eConsult, but it is slightly different because telemedicine, you still are seeing the patient. So we're tackling that, and we don't always want the telemedicine policies to be blanketed and sort of applied to what we're doing, because again, it can introduce more constraints. The privacy aspect, so again, that's just a matter of making sure that people know what the current legislation is. There are slight variances between the provinces, but the essence is that you have to, if you do eConsult, it must be on a secured system. It needs to be able to transmit patient health information securely. It has to be in the circle of care. So those are sort of the pieces that that we're looking at. And I'm thinking, what else? What was our other one? We've written a few papers. Looking at Justin, so he's my policy guy. So the payment, the provider the basically licensing aspect. So as I said, I would like to be able to have the pool of specialists who could provide eConsult nationally. And there's interesting precedent. So the US military does that worldwide, and then the other one, Kevin, I'm looking at you, MSF does that. So MSF uses telemedicine, but also eConsult. And I talk to, military is different because they are actually regulated and licensed under their own sort of umbrella. So I'd love to, we actually are working with Canadian military, but try to maybe get that in here. But the MSF one is people, they're volunteering. So the specialists who are doing it basically volunteer to provide the consult service, but they broker it in the same way as we're doing conceptually. They try to, and they do it more by time zone, but they get around sort of the interjurisdictional aspects and some of the liability aspects because it falls under the Good Samaritan principle, and there's no business transaction. So it's interesting. So when you put a business transaction into medicine, then it puts in a whole layer of different rules, which then are provincially driven. But if you take it above that, then you can get around it. So again, that's kind of where we're hoping to get to. And it's really about looking at what's the existing policy, how does it apply to the eConsult scenario, and then maybe there needs to be a slight change in the language or the way the policy is, that could then enable basically eConsult. So that's the policy research I'm doing. So.
Question by Dr. Diane Dalma.
Yeah.
First off, congratulations, Claire. Do you see a threat to this from those specialists who are providing primary care? So I recently received a notice from an OB who claims they provide low-risk OB care, or those that keep seeing a patient when they can be looked at after by the family physician. Perhaps this is not your focus.
Yeah. So that's a great question, Diane. And I think, to me, some of the specialists in the way that they do their practices, it may not be conducive to eConsult, which is fine. And I think, to me, I don't really see it as a threat. I see that there's so much need, and the whole reason that we exist in terms of the eConsult system is to enhance that access. So as long as people are going to be sitting on a waiting list to get care from different specialty groups, then there's basically a need and there's value to eConsult. The individual specialists themselves, depending on how they work and do their practice, is really less of a focus for the, why we have set it up. But clearly it can be used, but not in a threat way. So I just need my group and my bank of willing specialists who want to be innovative, who are motivated to deliver better care, who like to be collegial, professional, and basically provide that access. And there's so much, I think, medicine and work to go around that nobody is going to sort of lose their livelihood over it. Any other questions online? Okay.
So you mentioned your decision not to commercialize the platform. And sort of with that in mind, can you comment a little bit more on funding and what type of funding you got for the development of your platform in the sort of earlier phase?
Yeah.
And in the later phase, I guess, to fund these policy scans and all that. Because as you said, it doesn't fit within sort of traditional research framework for CIHR, and it becomes, it's sort of new land when you start going into that area as to how you're going to keep funding the work and keep your people, and that's a big challenge, and it's not something that we're sort of used to as researchers, as sort of traditional researchers.
Yes,
right?
absolutely. Okay, so let me answer the first question on the technology and the cost in terms of the platform development. So the first grant that we wrote pitched this idea, but using email. And it had no money in it to do any platform development. So here's, again, take risks, but also I was naive, right? We get the money, and then it's like, oh, hang on a minute, we didn't really think about the patient privacy, right? And in fact, at that time, there was a policy that got released from the College of Physicians and Surgeons of Ontario and CMPA, which was advising physicians not to use email for patient health information, although people still do that, right? Because it wasn't secure. So what did we do? We didn't have a lot of money, like it literally was a $100,000 grant for 18 months. So I knew that there was not going to be enough money to go and work with a vendor. We've done, as I said, another project where we work with a vendor, and you got, you're not out of there. You can't pay less than $20,000 or maybe even more, right? So we went around, and basically that's when we went and begged and borrowed and met a whole bunch of all of the institutions around and asked the question, here's our idea. Do you have a secure platform that we could basically maybe do some development on easily, of research staff, to try to build eConsult? And would you give it to us for free? And then also the other piece is, how many licenses do you have? Because if you join Oasis at the Ottawa Hospital has to pay, a user fee for each license, or if you have more users on an electronic medical record, you got to pay for that. So at any rate, so we ended up landing with the Champlain Lynn, who had just launched a collaboration space. So all of us are using those now. So this is like LynnWorks, it's SharePoint, off the shelf. And on that one, it was already basically, and all of the regions in the province had done it. So it was all done on a private secure network. And then you had the ability, you can build your own forms, which is essentially what we were doing, right? Like Erin and I, all it is could we communicate with each other electronically and then meet all the privacy requirements. So really very simple approach, and so that's what we did. And then we clearly had to do all the privacy assessment and all of that, but we never actually ventured into any relationship with any vendor.
So you piggybacked onto what was sort of
Already existing.
An existing
That's right.
private
Yeah.
sort of infrastructure.
Yeah. Yeah, it's the smart system. That was previously Smart Systems for Health. That's what it was called before. It was called eHealth. So it's a digital health platform that exists and is basically the network is a private network. So we knew already that we could build on that. So, and then we did the due diligence on the privacy assessment aspects and all of that. And then we had vendors who would love to have worked with us and just had made a decision no. And the reason why we did that is because the eConsult model is not about the technology platform. So 2 other provinces are using our platform, that's okay, but their final solution is not going to be the Microsoft SharePoint platform. It's going to be whatever they have in their province, and that's what we wanted. So it's not harnessed to one technology. And then also, I mean, it really, I've already had a lot of experience with EMRs, and one went bankrupt, one did this, we're switching upgrades. Every time you have all that, you pay for it, right? So we really didn't want that. Again, we wanted something very simple. And so that's what we did. I have 1 minute left to quickly answer your question about the, how do we get the policy piece funded and all of that. So there are CIHR grants. So I've been successful, Knowledge to Action grant, and then the Partnerships for Health System Improvement grant, very much aligned with what we were trying to do. And in both of those, I put in a policy objective. And it is the Institute for Health Services and Policy Research that reviews those. So those were very well received. And then I've gotten very creative. So last year we did not get a massive CIHR grant that I thought, we're going to get this, it's going to secure my program. We didn't get it, right? And I sort of thought, well, okay, we put it all together, we have our plan. I know the pieces that we want to do, and some of it is policy-related research. And maybe our national partners might also have that as their mandate. And maybe they might actually give me some money. So I, last May, went and asked for summer student funding. Canada Health Infoway, and then the Canadian Foundation for Healthcare Improvement. I think I asked the college, they didn't have anything to give us, but they were willing to sort of give us, be part of it. Canada Health Infoway did a video for us too, so I asked them for in-kind communication support in order to do some of the knowledge translation activities. So creative, some of it is that's not peer-reviewed funding, but that's okay, because if you can pay for a co-op student, you can get one of your research questions answered, and then we keep going. So I'm still submitting for SPORE and the traditional ones, and but I would say that I really I kind of think about it like I just do. You want me to salsa? I'll salsa, right? And I want the waltz, we'll do that, right? So very sort of creative and really nailing in on, all right, what is the shared mandate, shared direction, the policy direction, who might already have allocated funding that then they would like to basically send my way. I'm modest in the requests, but I'll tell you, if you get 10, 10, 10, and 10, like that, you can do a lot with that type of money. So, all right, now I'm going to hand over to Gwen. So now we're going international. So Gwen is Gwen's our student about 1.5 years ago. She's highly organized. thought that she'd like to come to Canada to do her research elective, because that would make research more exciting to come here. And so she's going to now talk about her project, and she's done an amazing job. And I asked her, she's going to tell you a bit about sort of where she comes from in her program, and then lead into, sorry, back into eConsult. So,
Thank you.
thanks.
Okay, so good morning, everyone. Like I said, I'm Gwen. I'm a medical student from the Netherlands, and I'm here for my research internship of 4 months. So I'm actually very interested in family medicine and also in the communication between healthcare providers. So that's why I wanted to do my research internship with Dr. Liddy and her great research team. And today I'm going to tell you something about my research in progress, and it's about primary care provider adherence and patient communication after eConsult. And before I forget, so we were working with the Bruyère clinic, and they also offered me to get some clinical time in the Bruyère clinics to shadow some doctors, which I've really enjoyed. So I wanted to say thank you, especially to Debbie McGregor, because she's here now, but also to Jay Mercer and all the other doctors from the Bruyère family health team. So thank you. So the eConsult team is built on amazing collaborations and funding, and these are them all listed. And before I start, I wanted to say that I have no conflict of interest at all. So like we've mentioned, I wanted to tell you first something about my background, so where I'm from, and about my medical education. So I'm from the Netherlands. It's a very small country in Europe. I think everyone knows it. And I'm actually from Nijmegen. It's a city very east in the Netherlands, and it's close to the German borders. And I really like Nijmegen because it's one of the oldest cities in the Netherlands. It's more than 2,000 years old, so we have still a lot of beautiful old buildings. And of course, I wanted to show you our two main forms of transportation in the Netherlands in general. So we have our train station and the characteristic colors of the train company, the yellow-blue ones. And of course, we have the bikes. And this picture on the left is actually the bike cage in front of the train station. So a lot of people take their bike to the train and then take the train to work or wherever they need to go to. And there's one picture I have from a man. I don't know if anyone maybe recognized him.
Oh, it's like Nigel or whatever.
It's actually our king.
Oh.
So I've heard with the practice presentation, Justin said it's Donald Trump. So I guess he looks like a lot of people. But it's actually our king, and he's biking here in Nijmegen to celebrate with us that we were the best bike city of Holland a few years ago.
Where's his helmet?
Well, we don't use helmets. We're I mean, the bikers, we rule the traffic, so we don't have to use helmets. So the last picture I have is about a very famous walk. It's the Nijmegen March. It happens every year, and 4 days in a row, almost 50,000 people are walking 14 kilometers a day. And it started a long time ago, initially with a lot of military groups, and they call it the Walk of the World because a lot of military groups from all over the world are joining. And as you can see, in the middle is the Canadian flag, so also the Canadian Army has joined a lot of times. And also for the people who are not walking, it's a very fun week with a lot of nice activities. So now something about my medical education, because it's quite different than from here in Canada. So in Holland we have a 6-year program, which means that we go straight from high school to university. And we have 8 medical universities in the Netherlands. And well, I'm connected to the Radboud University. So what we have is that we have kind of 2 parts in the education. The first one is the bachelor's degree, and that's where we just learn, make exams, and learn more in books. And the second one is the master's, and then we're going into the hospital to get some clinical experience. So we have a lot of mandatory internship rotations, who take place from 2 weeks to 2 months, depends on which specialty. And then you have a few months that you can fill in for your own. So for example, I did a month with people who are mentally disabled or in the addiction clinic. And what's also very special about our program is that it's mandatory to do a research internship for at least 3 months, because they want us to know, to get some basic knowledge about research, because a lot of us are working with it later. And even if you're not going to work with it, it's still very convenient if you have some basic knowledge. Yeah, so that's partly why I'm here. So one last thing about the Netherlands, and then I'm jumping to my project. So our healthcare system has a lot of similarities with the Canadian one, but also some differences. So we have elements of a public and a private healthcare system, kind of the same as in Canada. But the difference is that we have private health insurance who compete with each other, and they have a basic package and a more advanced package, and everyone is obligated to have at least a basic package. And the way the government is involved is that they fund for the basic package, and they get to decide what's in the basic package. But for the rest, it's all up to the private insurance. Well, another very convenient thing is that we're such a small country, so everyone has easy access to their GPs or the hospitals, because we don't have to drive very far. Well, the same as here, the general practitioner has a central role, so you always have to go through your GP if you want to be referred to the hospital. But what's different is that we have after office GP posts, which means that before you go to the emergency department, you always have to go to the GP post first, so they can triage you if it's really necessary to go to the emergency department, which saves a lot of waiting time actually in the ED. But for the exception, of course, if it's really emergent, you just go to the ED if you call an ambulance. And then at last, we have almost as much outpatient specialist care centers as we have as hospitals, but they're mostly connected with each other. So when I came to Canada, I also wanted to learn, of course, about the healthcare system here. And one of the first things I learned is that it's really hard to get a specialist appointment, or it's not hard to get one, but you have to wait long for it. So the waiting times for 9 months, I've never heard of that before, so that's really interesting actually. So what we see here is actually it's out of 11 countries of the Commonwealth Fund survey, and what they've looked at is the percentage of patients that had to wait 4 weeks or more for their specialist appointments. And what you see is that at the Netherlands we're quite high, so only 23% of the patients had to wait more than 4 weeks. If we look at the average, it's 36%, and then all the way down is Canada with 56% that had to wait more than 4 weeks. So there's a really big difference in there. Yeah, so these are the slides we've already seen before, and we've talked a lot about the eConsult service, so I'm going to get over that quickly. But it's, like I said before, it's mainly built to get better specialist access. Yeah, so we're going over this quickly. So there's a lot of there are a lot of benefits for the eConsult service, and there's a lot of already known. So for example, the average response time is only 2 days, so that's very fast. And in 28% of the cases, the patient had to go to the hospital. And like was mentioned before, in 4% of the cases, there was a referral because of the eConsult. So the referral was not originally in mind of the PCP. Well, 57% of the PCP got a new advice through the eConsult service, which they could handle on. And we already heard something about the patient satisfaction, and but also there's a high satisfaction among the PCP and the specialist. So for example, in 92% of the cases, the PCP said that the eConsult had additional value for their patient. And what they said especially is that they liked the timely advice that was given. They thought it was good medical care for the patient, and they also said it had a lot of educational benefits for themselves. So there are a lot of benefits of the eConsult, but there are also some things that we don't know yet. So especially what happens after the eConsult. So what's the effect on the clinical management of the patient? What are the primary care provider actions after the eConsult, and how are they linked to the specialist recommendations? So are there any barriers for implementation of the advice? And as last, how is the communication back to the patient after the eConsult is done? Because that's where the patient is the middle of all of it. So if you look at the literature, there are two groups that already have kind of these questions and investigated them. The first one is from Gleason et al. 2017. They are from San Francisco. And what they looked at mainly is the PCP questions that were asked, the recommendations that were given, and if the PCP had implemented the recommendation. So they did a retrospective chart audit, and they looked at the implementation rate on 4 groups. So they looked at the lab tests, the imaging procedures, new medications, and medication changes. And what they found that was in the different groups that between 65 and 86% of the recommendations was implemented. So that's a very good start. The second one is about from Pacina, also from the USA, from the Mayo Clinic. And they did kind of the same, but they focused more on the communication part after the eConsult. So what they saw is that in 87% of the cases, there was communication of the results back to the patients. This was mainly done by the primary care providers themselves, through face-to-face contact or telephones, telephone calls, but also in 37% by the nursing staff. And what they found on the implementation is that 78% of the recommendations, of all the recommendations were implemented, and in additional 6% some of the recommendations were implemented. So these are already very good numbers. So this leads us to our primary research questions. So what's the primary care provider adherence to recommendations of the specialist after electronic consultation? Is our primary question, and how do primary care providers communicate the results of the eConsult back to the patients? So for our study, we chose to do it within one family health clinic, and we chose to do it within the Bruyère family health team because they're a very a big clinic. They have a lot of PCPs, and both doctors and nurse practitioners, they are using the eConsult service on a daily basis. And what also is very unique in this clinic, what they've done is that they implemented the eConsult form into the EMR, so which allows the primary care providers to stay in the EMR if they want to request the eConsult, and then they trained the clerical team to work with the eConsult service, so they work together. So that's very, it's a very unique way, very interesting. So our methods, we're doing a retrospective chart audit, and we're aiming for about 300 charts. What we're looking for is we wanted to know if the recommendations are implemented by the PCP, and we want to know the methods and time of communication after the specialist response. So those are the main key outcomes we're looking for. So we're looking for 6 months after the specialist response in the chart. So I've done all of the chart abstractions, but what we've done to maintain the quality of the chart abstractions is that we implemented 3 checkpoints over time, on which Dr. Liddy checked 5% of the cases. And then, of course, we discussed the results and we talked it through. What we've done first is that we classify the primary care provider questions and the recommendations in 5 main groups. So we have diagnosis, drug treatment, management procedures, and others. So for the specialist recommendations, we also have a lot of subgroups, which I will explain later with the results. So if we classified the questions and the recommendations, what we look for then, if was the recommendations followed by the PCP? And like I said before, we do it in 6 months over time. So we look 6 months in the chart after the specialist response. So yes, if the evidence was followed. No, if there's evidence that the recommendation is not followed, and then we know it's also the reason why it's not followed. So there's a number of reasons why the recommendation could not be followed. We select no sure if there's no evidence at all in the chart, so we don't actually know what happened there. Important to note is that we're checking the adherence from the PCP levels, which means that if the specialist advised the patient to do something and the patient declined it, then it's still implemented. Because we're checking it on the PCP level. So the next thing we're checking for is there's documentation of communication of the results back to the patient. So yes, there's documentation, no, there's no documentation. And not sure is selected if there are particular follow-ups for the same symptoms which were the eConsult was sent to. But we're not sure if they also discussed the content of the eConsult and if they discussed the recommendations. And of course, if yes is selected, then we choose the method of communication, and we select how many days after specialist response. So also here important to note is that we select the first attempt to inform the patient. So when I first started, I thought that the classification would be very straightforward. But when I did some charts and I got along the process, there were some things that were not as black as white as I thought it would be. So we had some challenges, and I wanted to take you through some of them to take you through our thoughts. So the first one is about what do we do if there are multiple recommendations are given. So this one is, for example, dermatology referral recommendation, and it talks about the first step is to do one particular treatment. If that doesn't help, do another treatment, and if that doesn't help, send to dermatology. So the particular question with this one is, how do we classify this? Do we note all the 3 different steps, or do we look at the main advice that is given? So what we decided is that we wanted to focus on the main question that was asked by the PCP and that linked to the main recommendation that was given. So we're looking for the overall advice that is implemented. So we chose to only select the initial recommendation. Then we have the category do nothing, watchful waiting. So for example, something comes up on an ultrasound, a kyst or something. The PCP asks, do I need to have more workup for this? And the specialist says, no other imaging is recommended, or no other workup is recommended. So first I thought, well, do nothing is not something you can implement. And that is true, it's not something you can implement, but it's still a recommendation that you can follow. Because there's still, the patient can be reassured that nothing has to be done, and that is still a recommendation that you can follow. And that's all has to do something with the Choose Wisely campaign, which I will come back to later. So then we have the if recommendations. So for example, this recommendation actually says, I'm not really worried, but if the patient is anxious, you have enough reasons to refer. So how do we classify this? Is this a do nothing? It depends on what the patient says, or is this referral recommendation? So we decided that something like this is a recommendation about referral, and it's implemented if the PCP talks to it with its patients, talks it through, and even though there isn't an actual referral, it's still implemented if the PCP talks it through with their patients. The last one is about recommendations that are already implemented. So for example, this one has foot pain. The recommendation is to get a good orthotic shoe, but in the history of the patient said that they already had one. So how do we handle this? Can this still be re-implemented or reinforced? And the answer is yes, because for all the PCP knows, the shoes are back in the closet and the patient hasn't used them for years. So things like this can still be talked again through, hey, are you still using it? Is it helping you? So recommendations that are already used can still be implemented again. So this is actually my part about the methods, and before I go to the very exciting results, I was wondering if anyone had questions up so far. No? Okay, then I'm just going through with my results. So I hope you're ready. So what we've done for this presentation is that we selected data from 115 cases, and what we see is that mostly dermatology cases that are involved, followed by OBGYN and endocrinology. If we look at the particular primary care provider questions that are asked, we see that if we look at the top 3, we see that the most questions are asked about diagnosis and interpretation of clinical findings. And that also gets together with the dermatology, because with dermatology there are a lot of skin problems which are pictures sent for because PCPs don't know what the diagnosis is. The second one is about general management. So for example, if you already have if you have a patient which the diagnosis is clear, you already have tried a couple treatments and it doesn't work, what to do next? What are the next steps? And then we have diagnosis and interpretation of prior testing. So if a patient had some workup for, I don't know, fatigue, and there was one of the labs that was slightly high and they didn't know how to interpret it. So now we're going to the actual results. So if we look at the data for the overall implementation, if we look at the pie chart at the left, we see that in 85% of the cases, I see some stuff, that's good. But in 85% of the cases, the PCP followed the recommendation of the specialist. so that's very high, and very good. In 5% of the cases, there was a reason why, or there was evidence or reason why the PCP didn't implement it, and in 10% of the cases, we don't know. There was no documentation, so we don't know exactly. So if we got the right, these are the subcategories for the recommendations. These only contain the categories that are 10 or more recommendations in it. So if we look at the drug treatment, the implementation of new drug treatment, that's the recommendation that's given the most. So it's accounts for 20% of the recommendations, and it's followed in 77% of the time. So if we look at the watchful waiting do nothing, that's very interesting. That's on the second place. It accounts for 30% of the recommendations, and it's followed in 81% of the time. And then the managing is followed in 100% of the time. The imaging, I mean, so it's followed in 100% of the time. So that are the X-rays, the ultrasound, CTs, MRIs. Then we have management other. That's kind of a broad category, but it's followed in 67% of the times. An example for the management other categories is the recommendation to try physiotherapy, the recommendation to try very good solid shoes, the recommendation to moisturize, all that kind of things that don't fall into the imaging lab or drug treatments. The recommendations are from follow-up are followed in 85% of the cases. And follow-up is if they say check the blood pressure after 3 months, or monitor the skin problem every year. I have recommendations like that. The lab is also 100% followed, so lab is blood work, with also urine cultures, viral bacterial swabs. And then the last one is the recommendations, other recommendations. This is also a very broad category, but these are more recommendations that are not really hard recommendations, so more overall information that is given. So for example, one of the patients wanted to know some details about an operation, a particular operation, and the PCP asked the specialist to give some details, how it works, how many recovery time, stuff like that. So these are the reasons why the recommendation couldn't be implemented. So we see that in 3 of the 6 cases, it was because the patient's symptoms were resolved, so the treatment wasn't needed anymore. In one of the cases, it was because the PCP thought that another diagnosis was more likely. So the recommendations for diagnostic workup weren't accurate anymore. So one of the patients had already used the drug before, and in one of the cases, the eConsult came in too late for the patient's request. So if you now look at the data for the communication, if you look at the pie chart first again, we also see a very high rate of documentation of communication. So in 81% there was documentation of communication back to the patient. In 9% there was not, and in 10% we weren't sure. There were follow-ups, but we weren't sure. So if you look at the method that is most used, it's mostly the PCP themselves that do it by face-to-face contact or by phone. And in 20% of the cases it's done by the nurse via the telephone. We see that the average communication time is 17 days after specialist response, and the medium is 5 days.
Do you want to highlight the email on top?
Yeah. Oh, sorry. Yeah.
Not everybody knows what they have there.
Yeah. I understand. So what we see that in 12% of the cases, the PCP contacted the patient through email, and that's actually through the patient portal. So that's a very convenient way, because the patient has the recommendation on text, so it can read it over again, and it can be done in their own time. And the other one is actually face-to-face contact with the nurse. So I wanted to come back on the Choose Wisely. Is there somebody who ever heard of the Choose Wisely campaign? Yeah, I see a lot of nodding, that's good. So the interesting thing we saw with our data is that 30% of the recommendations was to do nothing or watchful waiting, and it could be to do nothing, no further investigation is needed, no treatment is needed, or no referral is needed. So they started the Choose Wisely campaign in 2014 because they saw that there were a lot of unnecessary tests and treatments done. And the goal of the campaign is to let the patient and the PCP knows about what are the responsible steps for further And it's all about the patient safety because they don't want to over-investigate the patient and maybe find things that are not of any clinical value. So they want the patient and the PCP to engage in that step. So my last slide, the conclusion. So what we saw from this data is that the PCP adherence to specialist recommendation is very high, which for me underlines the value of the eConsult service for both patients, PCP, and specialists. We haven't found a lot of barriers for implementation yet. And there is also a high percentage of PCP communication back to the patients, which the PCP mainly handles themselves. And at last, we saw that the eConsult service also helps to choose wisely. So this is my thank you slide, and I want to particularly thank you to Bruyère Family Health Team again of using their data. And thank you all for listening. So does anyone have any questions, comments, advice for us?
Yes. There's some online ones. We'll do the online one first. Yeah.
One question, Dr. Diane Dalva. Do you know how many of these are e-consults initiated by the resident doctor? And I'm not sure what she means by this question. Would this affect both the questions and the follow-up?
Yeah, so I understand. That's a good question. I've looked at it in the beginning, but it's very hard to see if the resident initiated it because most of the time the resident is supervised by the PCP, and also sometimes we know if the residents have initiated it, but it's always someone. A lot of times it's someone else who follows up with the patient and who implements the advice. So I think there's no link to going that. I don't know if you have any issues with that.
No, I mean it's the resident if they basically get access as a delegate, but the family physician or nurse practitioner remains the MRP. So as you said, they are often the ones who make it. So we don't have that, cannot access that level of data.
So it's not documented somewhere that the resident with their signature.
They are not in it. No, they are doing it on behalf of their supervisor. It would be documented, I suppose, in the chart if you started at the beginning.
Any other questions?
Yeah, so thank you. Great job. I think you're doing a great job so far, and I hope you find a lot of good information while you're doing your research. So just comment and questions. So comment with the for the nominal group technique. One of the primary care providers actually wanted as an item, the e-consultant uses words that the patient can understand. Does that make sense? So if you're trying to look at your, how does the primary care provider talk about the information with the patient? If as an e-consult, since we write it as if we were talking with the patient, that's what one of the primary care providers wanted. But the rest of the room said, no, we don't like that. So yeah, I just wanted to put it out there. And the question I had, so a lot of dermatology, hey? When you add it up, you might have to talk about that. Because I think all e-consults is about 16% is dermatology. So what you have so far is 40%. So how do you think that might affect your results? How do you think you're going to talk about that in your discussion?
That's a good question. I actually haven't thought about it that much. I'm not sure if it's really going to affect the results, but you can imagine that with dermatology, there are a lot of the same recommendations because they use a lot of the same drugs for a lot of diseases. So if you think about that, it could be that there are more of the same recommendations that are given and more of the same questions that are asked to the PCPs.
We can stratify though. We could create basically if it ends up at the end of 300 still a high proportion of derm cases, then we could basically do a sub-analysis and compare exactly what Chris is saying for derm compared to the rest.
Yeah,
So.
Yeah, that's a good suggestion. Any other?
Other questions? Any questions about
Yeah.
liking and Netherlands?
I was just wondering for the cases where the recommendations weren't followed for the various reasons you mentioned, did the communication continue between the primary care physician and the specialist? For example, I'm not going to implement this because the patient already tried this medication, and then the specialist would give another recommendation, or did the primary care physician just end the communication and chose not to go further?
Well, that's a good comment. I haven't seen that they chose to do it But there is like the survey questions in the end. There's also an option to say, I'm not going to implement this recommendation because I can't. But the thing is that in the church I'm looking at, we can see the survey, so we can't really know what's happening there. And I haven't seen that they're going. I mean, I have seen that they're going further, but that are always the recommendations that are implemented. I haven't seen it if they're not implemented.
Dr. Diane Dalba, so this is where I wonder if the residents are less comfortable for derm and you have the ease of adding photos. So she noticed once that a resident referred both to allergy and derm at the same time, so they're definitely not choosing one.
Okay. Yeah. So, Diane, we need one of your residents who'd like to maybe do that as a resident project at Bruyère. Gwen is leaving us at the end of the month. Great question.
Okay.
Any other questions? All right. Well, thank you for journeying with us all. So we have big data sets.